Very good afternoon, everyone. Today we are going to discuss about plasma cell neoplasms. Okay, so this actually we are going to discuss in detail about multiple myeloma. So for today's specific learning objectives include at the end of the session, you should also all be able to know about the classification and regarding different clinical pathological entities related to plasma cell neoplasm. And you should also be able to describe the pathogenesis, morphology, immunophenotyping, clinical features, diagnosis, prognosis, and treatment of multiple myeloma. So we'll see each one by one. So by definition, plasma cell neoplasm is considered as a group of lymphoid neoplasm, which is containing of predominantly terminally differentiated B cell. You know what is B lymphocyte derived from, right? So this group of neoplasm consists of terminally differentiated B cell, which are in turn contains neoplastic plasma cell. So it is not a normal plasma cell that virtually always secrete a monoclonal immunoglobulin or an immunoglobulin fragment. So it can be a intact immunoglobulin or just a fragment of immunoglobulin which act as a tumor markers and often will have a pathological sequence. Though you know antibodies or immunoglobulin are very important for protective mechanism of our body, these are unwanted immunoglobulins which are actually going to cause damage to our body, so which leads to pathological consequences. As I said, you should be know about some of the clinical pathological entities like multiple myeloma. As the name says, it is going to be of multiple lesions. Okay, so but there can also be terminology called solitary myeloma when it is a single lesion, which is also known as plasmacytoma, and there is something called a smoldering myeloma as well. The second terminology is MGUS, which is nothing but monoclonal gammopathy of undetermined significance. We'll see one by one what is it. And third most important clinical entity is that Waldenstrom's macroglobulinemia. Then comes heavy chain disease, and finally primary or immunocyte associated amyloidosis. So here you can see it is actually a spectrum of disease starting from monoclonal gammopathy of undetermined significance, which later on progresses to multiple myeloma. In between, there is a category called smoldering myeloma. So this kind of categorization is basically based on the level of serum M protein and bone marrow plasma cell percentage, and also based on the presence or absence of related organ or tissue impairment, right? So we will now discuss in detail only regarding multiple myeloma. So what is multiple myeloma? Multiple myeloma, the word is derived from the terminology called myelo, which is in turn called as marrow. What is oma? Yes, of course, we learned in Neoplasms chapter, which is nothing but tumor. So in short, it is called as a tumor of marrow. So what does it occur is, it undergoes malignant proliferation of bone marrow derived plasma cells. So it is a lesion which principally involves the marrow but can also affect the bone, that is skeletal system. So in bone marrow, what you will see, I already said, it is a proliferation of plasma cell. So in bone marrow, you will see increased number of plasma cell. And what about in skeletal system? You will see many number of multiple lytic lesions of the bone. So that is why it is called as multiple myeloma. So it involves both bone marrow as well as skeletal system and presents clinically as multiple lytic lesions of the bone. So this, what is plasma cell? How do they form? Where do they form? And what is the normal function of the plasma cell? Is all that we already know. But we just quickly go through what it is. It is derived from a B lymphocyte. You know, B lymphocyte is derived from bone marrow, right? So B lymphocyte, when it gets exposed to an antigen, it gets modified into a plasma cell. So the plasma cell function is that to secrete immunoglobulin, right? So what are the components of immunoglobulin? You have a heavy chain and a light chain, right? So there is a light chain which can be freely excreted in the urine, which was called as Banks-Jones protein, because it was first discovered in patients of myeloma, which was identified by a person called Benz-Jones in the urine of myeloma patients. It is called as Benz-Jones protein, which is nothing but the free light chains which are getting excreted in the urine. So whatever antibodies thus produced by the plasma cell could be a monoclonal or a polyclonal. You know what is monoclonal and polyclonal, right? So polyclonal is basically can identify multiple epitopes of antigen, whereas monoclonal can identify a single specific epitope of an antigen. So of these two, the polyclonal antibodies could be of reactive nature, whereas what is most important and clinically significant is that the monoclonal antibodies which are produced by the neoplastic plasma cell. So that is what happening in myeloma. So what happens in multiple myeloma? There is excessive abnormal plasma cells which are labeled as myeloma cells, which are going to produce or in turn overproduce intact monoclonal immunoglobulin or a part of immunoglobulin, that is immunoglobulin fragment, also called as paraproteins, okay, which are actually an ineffective immunoglobulins, or it can be just a free light chain fragments, which could be either kappa or lambda light chain. So what does these overproduced immunoglobulin is going to do is that it is going to cause decreased bone marrow function and also causes destruction of bony tissue. That is why you get a lytic lesions in case of multiple myeloma. So these kind of immunoglobulins which are thus produced can be of various types, like our normal immunoglobulin. It can be IgG, A, M, D, E, of which 60% of the cases could be of IgG type. So as I said in the beginning, it could be a free light chain immunoglobulin as well, which could be kappa or lambda light chains. When it gets excreted more in the urine, what do you call it as? Benzone's proteinuria. So here in this, we will be repeatedly looking into a terminology called M protein or M component or M spike. Okay. So what does that M protein is called as? This M protein is nothing but a monoclonal immunoglobulin which are identified in the blood of a patient, which is referred as an M protein. This is called as M in reference to myeloma. So coming on to multiple myeloma, it is the most common primary malignancy of the bone and its incidence increases with age. So as the age increases, it also increases in incidence. So median age of diagnosis is around 70 years, though it starts around 45 to 50 years. The most common etiology is following radiation exposure or exposure to pesticides, petroleum products, mutation in oncogenes such as cyclin D, and there are some familial causes also which plays a role in multiple myeloma. So basically it is a multifactorial agent. So it is more common in males than females and it's more common in blacks compared to white skinned people. So this is what the plasma cell myeloma recent update for diagnosis. It has to meet both the criteria, that is one criteria is clonal bone marrow plasma cells more than or equal to 10%. We discussed just now, there is overproduction of plasma cells in the bone marrow. So you have to look at the bone marrow. There should be an increase in number of plasma cells more than or equal to 10%. And it is not just the number of plasma cells, it should be a clonal plasma cells. So it should be a monoclonality should be demonstrated, or a biopsy proven bony or extramedullary plasmacytoma, also called a solitary myeloma. So if there is an extramedullary plasmacytoma or a clonal bone marrow plasma cells more than or equal to 10%, in addition to that, there should be another criteria, that is any one of the following. Of this, number one is evidence of end organ damage. Number two is clonal bone marrow plasma cells alone or involved free light chain ratio of more than equal to 100. And there can also be just more than one focal lesion on MRI, which is just about 5 millimeter size. So in evidence of end organ damage, you have a lesion called, in short form, it is called as CRAB. C for calcium level. When you see the serum calcium level, it should be elevated and the cutoff is 11 milligram per deciliter. So when there is more than 11 milligram per deciliter of serum calcium, it comes under evidence of end organ damage. Then the second one is R for renal insufficiency, where it is demonstrated by serum creatinine level more than 2 milligram per deciliter. Similarly, A for anemia, hemoglobin less than 10 gram per deciliter. And finally, it is B, which is bone lesion, where the lesion is demonstrated by CT or PET-CT scan by one or more osteolytic lesions on skeletal radiography. It could be a simple X-ray also sometimes, which can show a lytic lesion, but when it is not available, you have to demonstrate by CT or MRI. So there is something also called as myeloma defining event, because in myeloma diagnosis, one of the criteria is end organ damage. So we need not wait for the patient to reach the end organ damage, because you can early identify the myeloma by means of myeloma defining event, which is SLIM criteria. That is 60% clonal bone marrow plasma cell, and LI is for serum free light chain ratio of involved and involved more than or equal to 100, and M1 is for focal lesion, which we discussed in the last slide. So coming on to pathogenesis of multiple myeloma, it has got a multifactorial etiology, which is discussed right now. But then what are the two pathways by which it leads to the mechanism by which myeloma develops is that one is via hyperdiploid. 50% of the cases undergoes hyperdiploid mutation, and the second 50% is by non-hyperdiploid agent. So the non-hyperdiploid pathway is usually associated with IgH translocations that fuses the IgH locus on chromosome 14 to the oncogenes such as cyclin D1 and cyclin D3 gene. So this is the most important molecular pathogenesis that is behind the multiple myeloma, which is included in current edition. So coming on to clinical features, what we want to know most importantly is how does the patient present. We just gone through the diagnostic criteria for multiple myeloma. So how does they present clinically is that it can be sometimes asymptomatic, but many times symptomatic, which falls under either roti or crab. Roti is nothing but myeloma related organ or tissue impairment. Crab, we just discussed, it is elevated serum calcium, R for renal failure, A for anemia, and B for bone litigations. But definitely patient will not be coming to us saying that I have a high calcium or a renal abnormality, right? So we have some of the clinical presentation of the patient, which is nothing but very commonly they present with low backache. So generally when an elderly patient with low backache, you think of osteoporosis, osteopenia, or arthritis, those kind of things. But we should always keep in mind, we should always rule out multiple myeloma when other features are also there. So the commonest presentation is pain in the low backache, long bones or ribs, and similarly some of the very non-specific symptoms like generalized malaise and weight loss are the commonest presentation. And as I said, if the renal involvement is there, we have other symptoms like hyperviscosity, because the patient is have high amount of immunoglobulin in the blood. So they develop symptoms of hyperviscosity due to hypergammaglobulinemia. So they will have headache, visual difficulty, bruising, and neurological symptoms. So what are the common sites of bone involvement is that almost all important sites like skull, vertebra, pelvis, which are the commonest sites. The classical is that the spinal cord involvement, because of the involvement of the vertebral bodies, can also undergo pathological fracture, thereby compression of the important nerves can occur. So as we discussed, the pathological and clinical features we just discussed, these are basically due to three major mechanisms. One is due to tissue infiltration of the neoplastic plasma cell, because of which what happens? It undergoes pathological fracture and chronic bone pain. And second most important is production of large amount of paraproteins. So it is there more in the blood, as well as those unwanted things gets deposited everywhere in the body, especially the kidney. So which can lead to light chain deposition disease, amyloidosis, or cast nephropathy. And third most important pathophysiology is due to impairment of immunity, because of which patient can present with multiple bacterial infections like bacterial pyronephritis and so on. So as I said, it has many untoward effects. Though we have so much of immunoglobulin, it is all non-functional. It is going to cause damage. So it affects the skeletal system by means of upregulation of rank ligand by the bone marrow stromal cells, so that it activates osteoclasts, causing bone resorption and lytic lesions. So immune system, in which, as I said, functional immunoglobulins are reduced, so they are more prone for bacterial infection. Similarly, in kidney, main thing is the obstructive proteinaceous cast in distal convoluted tissue. So these are the list of investigations which are done for the patient. Though it looks very vast, what is most important and basic investigation is of course CBC, which is complete blood count, and skeletal survey, because blood and bone marrow and bone is the most common input. Then to quantify and quantitate the type of immunoglobulin or protein, you want serum in the urine, protein electrophoresis, which is second most common. And of course, the diagnostic confirmatory test is based on bone marrow aspiration and biopsy. And of course, the radiology plays major role. And there are some other criteria like beta-2 microglobulin and C-reactive protein, which are very important for the prognostic factors. So the first is radiology and laboratory test. X-ray can demonstrate multiple punched out, sharply demarcated lytic lesions without any reactive sclerosis, because for a bony lytic lesions, you have multiple differential diagnoses. So you have to rule out other primary bone lesions. So for that, the most important clue is this lytic lesion in bone, multiple myeloma, will be lacking reactive sclerosis surrounding the lytic lesion. So always suspect a lytic lesions which is lack of reactive bone formation as multiple myeloma, but of course the definitive diagnosis needs biopsy. So you can see here the X-ray of skull. Can you make out multiple punched out, well demarcated lytic lesions everywhere? Then second most common investigation is blood and bone marrow. In blood you have reduced hemoglobin level. Yes, because it is a chronic disease which is affecting kidney as well. So they present with normocytic normochromic anemia. ESR is highly elevated. Yes, why? Because the RBCs undergo rouleau formation because of the high levels of immunoglobulin in the blood. It undergoes stacking. So the erythrocyte sedimentation ratio also increases to the maximum of more than 100. Next most important is peripheral smear. Of course, you find a rouleau formation, normocytic normochromic anemia, whereas WBC and platelets found to be normal. Sometimes peripheral plasma cells can also be seen in the peripheral smear. Next and most important confirmatory diagnosis based on bone marrow. As I said, there is increased number of bone marrow plasma cells, so there should be obvious hypercellularity in the bone marrow. However, the erythropoiesis is diminished because of anemia is there, so there should be a diminished erythropoiesis, but it's of normoblastic nature. Whereas myelo and megakaryopoiesis predominantly of normal in condition, sometimes it can be reduced. So this is the peripheral smear picture where you can see the RBCs are just forming similar to the stack of coins which are arranged like this, right? So this is called as rouleau formation. Why this occurs? Because there is high serum immunoglobulin protein is there. So the blood is so sticky that allows the RBCs. So zeta potential is affected here. This is bone marrow where you can see numerous plasma cells. So how do you identify the morphology of normal plasma cell? There is eccentrically placed nucleus, the perinuclear half, which is basically due to Golgi apparatus. So this is plasma cell. And what is this? Something binucleated plasma cell. And this is also another plasma cell where we can see cytoplasmic vacuoles. It is actually not a cytoplasmic vacuole. It is nothing but cytoplasmic immunoglobulin droplets, which are seen in the cytoplasm of the neoplastic plasma cell. So when it is too much, It comes together and forms like a grape-like cluster-like appearance. So it is also called as Mott cells. So when it is overproducing immunoglobulin, the periphery of the plasma cells can also be thrown in the form of flames. So presence of plasma cells binucleated form or any other abnormal form, presence of Mott cell, flame cell, or all features of abnormal plasma cells in the bone marrow. And there can also be atypical plasma cells or plasma blast also can be seen. So this is all about morphology, what you see under microscopy. There are some additional investigations like immunohistochemistry where these plasma cells are highlighted by CD38 and CD138, which is the immunohistochemical marker which highlights the plasma cells. So as I said in the beginning, there are some serum findings like beta-2 microglobulin level, which acts as a prognostic marker to follow up the patient. Of course, you want to follow up the serum calcium level, yes, and similarly the renal function by blood urea nitrogen level. So electrophoretic study, you know very well in detail in your first year, but electrophoretic study can be done both in serum and urine. So you can do electrophoretic study or can show abnormality only in secretory type of myeloma. But there is around 1% of myeloma who are not secreting the immunoglobulin in the serum or urine. So they are called as non-secretory myeloma. Hence, the absence of M component you should not supposed to rule out the diagnosis. Rather, the clinical suspicion is always very important. So this is the normal electrophoretic pattern, the lower one you can see. So albumin, alpha 1, alpha 2, beta and gamma globulins. So you can see the normal is very sine type of wave, and polyclonal, just a reactive proliferation of plasma cells will be little bit higher wave. But what you see, this pink one is the spike, very sharp spike in the gamma globulin region, which means it is the monoclonal protein which is too heavy, right? That forms a spike. So that is called as M spike or M component. So after bone marrow and the bone, what is the next common organ which is commonly involved in myeloma is that the kidney. So the causes of renal failure in multiple myeloma could be due to cast nephropathy or light chain deposition disease or primary amyloidosis, or because of the disease process itself, there is hypercalcemia which can affect the kidney, and in turn some nephrotoxic medicines can also cause renal failure in multiple myeloma. So what is myeloma nephrosis? Is that nothing but a renal change that occurs in myeloma. Multiple myeloma is called as myeloma nephrosis. So there are two main pathogenic mechanisms behind myeloma nephrosis. One is straight away due to intracellular cast formation. The cast formation is nothing but the proteinaceous cast, which is more and more getting stagnated in the proximal tubule. So that forms a cast of the proximal tubule. So that intracellular cast formation and direct tubular toxicity for the light chain which is getting excreted in the urine, both are responsible for the myeloma nephrosis. So the cast nephropathy is the most common finding in renal biopsy of a myeloma patient. How does this cast are formed? This is due to the light chain binding with the Tam-Hirschfeld mucoprotein, which is normally secreted by the tubular cells in the ascending limb of NA. Which combines together and form a proteinaceous cast, which is going to cast the appearance of the tubule. So that is why it is called as cast. There can also be multinucleated giant cell reactions surrounding the cast, and there are also epithelial cells adjacent to the cast which undergoes necrosis or atrophic change due to the toxic effect of protein. Other than this cast nephropathy, there are other changes that occurs in kidney, which includes metastatic calcification, which is basically due to bone resorption. There is lysis of bone, right? Breakdown of bone, which releases more calcium in the blood, and hypercalcemia, which can lead to metastatic calcification. Then the second common is that the light chain, AL type of amyloidosis. So what happens when this free light chains or gets deposited in the mesangium or the interstitium of the kidney, it undergoes amyloidosis. It involves the renal glomeruli and the blood vessel wall. Then the third important is the bacterial pyronephritis. Because of hypercalcemia, there can be a renal stone formation. Renal stone itself can prone to infection, further secondary bacterial infection. Or as we discussed previously, there could be a suppression of immunity which can also prone to secondary bacterial infection in the kidney. So they are more prone for bacterial pyelonephritis. So these are the changes, pathological changes that occur in the kidney. So what about the prognosis of these kind of patients? If left untreated, they have a survival of about 6 to 12 months. But however, the treated patients have a median survival of 4 to 7 years according to the morbidity of the patient. So what are the different types of treatments available for multiple myeloma is that number one is proteosome inhibitors. So what is proteosome inhibitors? The myeloma cells generally are prone for accumulation of these unpaired immunoglobulin chains, which will actually activate the apoptotic pathway. Then what about immunomodulators? Immunomodulators are the mainstay of therapy nowadays. The example is lenalidomide, which stimulates the degradation of specific proteins with oncogenic activities. Then the third is bisphosphonates to treat for hypercalcemia. And of course, there is mainstay of therapy is the hematopoietic stem cell transplantation, which is basically an individualized therapy. So a word about Waldenstrom's macroglobulinemia. It is a monoclonal gammopathy of IgM type. So you reverse the W into M. So this is IgM type of hypergammaglobulinemia, which is having a median age of diagnosis of 60 years. Here the patient presents predominantly with hyperviscosity symptoms like visual impairment, neurological deficits, and bleeding. The patient also can have organomegaly and lymphadenopathy, and lymphoplasmacytic lymphoma is the most commonly associated with Waldenstrom's macroglobulinemia. So these are some of the references. Thank you.